4, 3, 2, 1. Sir, we are live now. Now, sir, we can start the meeting.
Okay, thank you. Hi, good evening, good noon, and good morning, everybody. Let me introduce myself. First, I'm Dr. Yu Liang from China, Beijing Hospital, Shanghai. Today, I'm so happy to be a moderator of this Smiss AP webinar 2024. We will be focusing on the complication of minimally invasive spine surgery, and we'll be discussing how to avoid them. We all know that the minimally invasive spine surgery is getting more and more popular, both to doctors and to the patients. We know well the benefits of minimally invasive spine surgery are tremendous, such as less bleeding during the surgery, early recovery, shorter length of stay, and less analgesic drug use after the operation. But there's other side of the coin. Like any other procedure, minimally invasive spine surgery has the potential for complications. Unfortunately, complications are a fact of life and are at times unavoidable. Even so, before the surgery, we have informed the consent process, but the complications happens. So I think it's never too much to emphasize the importance of the complications avoidance of minimally invasive spine surgery. We all know that the common complications are including infection, dural tear, CSF leak, neurological injury, post-op radiculitis, hardware complications, or cage subsidence, pseudothyrosis, medical complications. So today, I'm happy to invite 4 speakers. They are all masters in the spine field, especially in the minimally invasive spine surgery. They are Dr. ANDREAS from Munich, Germany, Dr. MASATO TANAKA from Okayama, Japan, Dr. ARVIND KULKARNI from India, and Dr. JIANG from Beijing, China. So now let's go to the procedure of lecture. First of all, I'd like to invite Dr. ANDREAS. Let me have a brief introduction of Dr. ANDREAS. Dr. ANDREAS is an orthopedic surgeon who specialized in spine surgery. He completed his undergraduate studies in Munich, Germany, Basel, Switzerland, and Yale University in the US. He graduated from Ludwig Maximilian University, Munich, and completed his orthopedic residency at the University of Ulm, Germany. His fellowship training in spine surgery started at the University of Ulm with Dr. Patrick Kluge. Since 1997, he works in the Spine Center, Munich, Harlingen, initially as a staff surgeon, and since 2008 as head of the department. The more important thing is that he was also co-author of a very important textbook of AL spine. The title is Minimally Invasive Spine Surgery. In fact, I read it at least 3 times. So let's have Dr. ANDREAS. His topic might be complications avoidance of microsurgery, spinal microsurgery. Now, Dr. Kogi.
Yes. So, hello to everybody and greetings from Munich. I hope everybody can hear me. And my part now starting will be talking about complications of spinal microsurgery with a special focus on dural tear and bleeding complications. That was Professor Liang was already talking about was the beneficial circle of MIS, which I named it in this book he mentioned. We have intraoperative benefits in MIS surgery. We have immediate post-op benefits, and we have on a long-term benefit. And especially here, the less caring, less post-op pain, those is probably due to intraoperative hemostasis and something like this. But what we know is we do not talk about target surgery because target surgery remains unchanged. If you think about MIS, we talk about access surgery. But that means vice versa, that the complication spectrum for this type of surgery remains completely unchanged, meaning that neural structures, vascular structures, if you do the anterior MIS procedures or the transthoracic or anterior neck surgery, all this remains unchanged. And so I'm going to talk now about dural tear and hemostasis when I split the presentation into dural tear and into the hemostasis. Dural tear, actually, just have to mobilize a little bit. Dural tear has an unchanged prevalence. Those are probably papers which is about 10, 15 years old, but it did not change. And especially, for example, if we go on the lumbar spine, even in primary disc surgery, we have about 3-4% of dural tear problems. In spinal stenosis surgery, it's about 8 to 10%. And if we go then in revision surgery, whether it's a disc surgery or decompression surgery, that's going up to more than 10%. Well, doesn't move anymore.
You can try it again.
Yeah. Oh,
Yes.
great. Yeah. If we think about, thank you for this comment. If we think about the tools which we need, then even for if we have problems or which helps in the MS surgery, I am going to talk about microscope-assisted procedures, and the benefit among all those which you know from the microscope is that you have the control of the target area. But it's not only the control for you as a surgeon. If you have a dural tear or closing a dural tear, it's also here. If you see for the scrub nurse, if she has a nice monitor and she can watch it, and if it's an experienced nurse, she might know already what will be the next step would you, or the next instrument would you might need. Of course, we have different types to solve problems like dural tears from according to the instruments. They should be in microscope-assisted surgery, always bayonet-shaped, as you see here, whether they are the scissors or forceps or needle holders, and the high-speed drill. And for the suction device, it's important that you have a type of control where you can reduce your suction power, because if you have a dural tear, if you have a problem like this, it's important to reduce the suction power immediately, otherwise you suck out the dura. And then other auxiliaries will be the patching material. That is quite different. You have Luoplan, or they are collagen based, or they are these tissue layers which you can put from inside outside. And then there are the sutures. Usually you are between 5 and 7, 5.0 or 7.0. What is important is this different type of needles. If you have a needle like this one, so see one needle, you see that the diameter of the needle is bigger than the diameter of the suture itself. That means if you make a suturing with this type of this needle, usually then you will have some CSF leakage directly next to the suturing. So it's important to have a needle like the TF needle where the diameter of the needle is smaller than the suturing which you use. So if we go now to the dural tears, the most common is the posterior dural tear, as you see here, and less frequent is the lateral laterals, and which might usually in the axilla or the exiting nerve root. And then if you have anterior dural tears, those are pretty difficult to solve because you can do it transdural, as you see here, opening the dura and then go through the thecal sac and go to the anterior part. And of course, if you have disc surgery before, I would recommend to fill the disc space prior to this. And of course, you can have different type of tears. You can have a hole, which is easily to close or even to patch. You have a slit. It's also easy to suture, but a little bit difficult. As you see here, would be a defect. You have a defect here. You have a defect somewhere here. And so this is a little bit challenging for the closure. So there is one, from my point of view, especially for the younger surgeons, which is like a cooking book, this paper from Luca Papavero about incidental durotomy in spine surgery, first aid in 10 steps. In the important papers, I put the QR code there. So for those who are just watching the meeting, they just can take the QR code and then they have the publication already. There are 10 steps. He called it Berdoff, MD. But the first step, probably the zero step, is that you have to place the patient. The highest position of the patient should be the dural tear in order to reduce the CSF leakage. And though we are going through this now, the B means bone removal. If you have to manage a dural tear, it doesn't, for beginners, they just get a little bit irritated and they want to start to close the dural tear. But if you do not see the end of the dural tear, it's quite difficult to start suturing if you have to suture. So you have to see the entire dural tear from caudally to cranially. That means with a high-speed drill, you have even enlarged your approach in order to see intact dural in all medial, lateral, cranial, and caudally. So if you have this, then even for beginners as well, it's important to do some suspension stitches. If you have stitches, or you can do this, if you have stitches on both ends of the dural tear, you can lift it up. That means then if you can lift it up, you have an easier intradural inspection. You can reduce neural fibers and can put a neuro padding or even an inside patch you can do already, like if you use Tachosil, you can put it, well, let's say upside down or inside out. You put it inside with the yellow surface to the surgeon. And that means then that CSF pulsation already pushes the pad against the intradural surface. And then as soon as you have a stop of the CSF leakage, then it's much easier to close it. The way you close your dura it's from scientific point independent. There's no difference whether you do single stitches or a continuous suturing. Both is likewise valid. And then if you have closed it, of course, like if you see here and then like here, and then you do an outside patch as well. If you have a very small hole, you do not have to suture this hole. You can just do a monolayer or even a double layer of an outside patch. But in this situation, if you have closed this here and closed this here, you have an inside patch here, close it by suturing and make an outside patch as well. And then if everything is closed, we always recommend a PEEP at least 40 and then for 30 seconds, known as Valsalva maneuver. And if everything is now safe and if it's closed, then I would recommend to put a tension-free pedicled muscle flap on top or in the dead space here in order to close the dead space and in order to avoid secondary CSF leakage. Second last step would be then a multi-layer closure, meaning it's always helpful to put the paravertebral muscles with anchoring stitches to the spinous process. That means you prevent dead space as well. You made an inside patch underneath the fascia, a deep skin suture, and no wound drainage. If you still are not sure if you have a complete closure of the dural tear, then should put in a lumbar drain. Usually it's 2 disc spaces or 2 segments above the dural tear. And you can place the patient post-op in a prone position. You should have your drainage with a drop level at the glabella. This is the amount like 500 cc per day, which might create mild hypotension headache. And then you have a 48-hour drainage. one overnight block, and then you remove it. This is the topic of intradural or dural problem. But the other thing is intra and post-op problems of bleeding. If you have an intraoperative bleeding, so to switch over now to the bleeding and hemostasis, if you do not see your target area, you have a reduced clearness, you might oversee your pathologies, you have a risk of tissue damaging, prolonged time of surgery, and decreased effectiveness. But this is only intraoperatively. Post-op, you have, as you see here, you have an increased scar tissue formation. It means also increased infection risk, increased revision risk as well. Epidural hematoma basically are not as, or let's say they are more frequent than expected. There's a study from Sokolovsky, and he put a series of, I think, 100 cases without symptoms or with symptoms in an MRI, and he could show that 58% of the patients have an epidural hematoma. It must make symptoms, but it can make symptoms. And what is important, that even about 30% of those candidates which had a surgery had also an epidural hematoma in a non-operated neighbor segment. This recent paper from the Asian area, they showed that in lumbar decompression surgery, if you have this amount of surgery, you have in about only 1%, let's say, that it could be symptomatic. And that is in this from another paper from this team here as well, that usually 80% are asymptomatic. He made a ratio between pre-op canal, post-op canal, and you could say if the diameter of the canal in a situation of an epidural hematoma is less than 20%, then you might have a problem with a cauda equina. So how are the tools to reduce the bleeding and improve safety? The microscope again, as you see here, the microscope again gives you the possibility of making a meticulous point-orientated bleeding, whether you use a bipolar or whether you use any substances. I'm coming to this in a second. And of course, we have the hypotensive anesthesia. That's a nice paper on the market as well. And they could show if the blood pressure during the extubation procedure and immediately after extubation is more than 50 millimeters above the standard blood pressure of this specific patient, is a very high option that these patients will suffer on a post-op epidural hematoma. And of course, patient's position, as you need to know this, for example, for posterior neck surgery, we call it the Concord position, but sometimes if you have to place the patient in a prone or supine position, then patient's positioning is of less value. And then now we have the different techniques of hemostasis. What everybody knows is bipolar the coagulation. You can do this in a microscope or even in an endoscope, of course, or exoscope by protecting the neural structures and make a very sufficient post-operative hemostasis. Important is the small detail. If you have standard BPOs, that is on the left side, you see that if you have your coagulation with the heat transfer, and if it's a standard bipolar, then after losing it, you have a tissue adherence and your heat transfer and the hotspots, they rupture. So you should always go for a silver coating, because then if you open your bipolar pincet, then you do not have the problem. Vasoclips are on a posterior approach nearly of no use, but if you go for anterior surgery, especially here minimally invasive lumbar O-lift, X-lift or A-lift, whatever kind, then it's important to have the clips at least on the table, because this is sometimes some ugly bleeding. We have hydrostatic pressure, we have epinephrine, which is rarely used, or H2O2 and bone wax for the local sealing, but that you can do with the high-speed drill as well. If you go now to chemical agents, we have those foams, sponges, whatever, gel form or gelita. We have the gelatin sponges, which are from purified animal gelatin. There's a contact between the gelatin and the blood, and this goes to a platelet aggregation. It can swell, and if possible, usually we recommend in our team to take it away. However, if you have a continuous microbleeding and it will not stop and you don't have other tools, I would not hesitate to leave one of those gelatin sponges right there. Other ones, likewise identical, is oxidized cellulose, Surgicel, Oxycel, or Tapotemp, whatever. and microfibrillar collagen, which is ARVIND. But all of them has the capability of swelling and the capability of swelling here as well. And some of them might at least have a small chance of producing allergic reaction. Therefore, it's recommended to remove them. Well, not too much known is purified plant starch arista, which is a powder. You can put the powder in the operative MASATO. It's like an avalanche. An avalanche, if you have an avalanche in a vascular situation, or if you have a powder avalanche in the lung, you die not by don't have enough oxygen, but the powder closes the structures. And this is the same like here, this powder coming out here. Usually you should remove this because this really can activate scar tissue formations. The Rolls-Royce definitely is then the thrombine complexes. FlowSeal is the bovine-derived thrombine component. SurgiFlow is a porcine-derived thrombine. They are very, very effective, and you can use it even in the high cervical spine due to the fact that they work without pressure, and that's you cannot use usually in the myelin. Pretty new now in the late years is the use of antifibrinolytic agents, and the most used is TXA or tranexamic acid. There's a nice overview from the last time for the literature. Actually, then in the literature, there's a different, still a heterogeneity about how to use, when to use, in which form do you use it topically, do you use intravenously. We now started and do all our MRI surgery, like decompression surgery on the lumbar spine and the bigger fusion surgeries with a systemic application. We have a high dosage prior to the surgery. We do an intravenous bolus, and then we have a continuous intraoperative substitution. You can also use it topically, intramuscular. It's not on an evidence base at the moment, but that's what we usually recommend. So coming to the end, the most important thing, whether you have a dural tear or bleeding, is do not lose your control and just stay for patience. Because if you think about risk avoidance, one thing is pre-op patient selection. If you go for an anterior ALIF situation, it would be nice to know if you go to L5S1 that this is the left iliac common artery here. It's not difficult to mobilize it, but it's important to know it. And that means also you have to the analysis of the existing anatomy. This is a color-coded MRI here, actually, CT, and color-coded CT, and you see that's the situation before in the front of L4-5. Therefore, you might debate if it's better to go on posterior. If you have to control your situation, don't ignore a dual tear or don't ignore bleeding, because you have to pay otherwise the price later. You have to react immediately. You know that there are powerful agents available, but what you need is patience that goes to the end, that you have to think about in your surgical daily training about surgical strategy, training, and discipline. So thank you for listening. What's the first presentation? Looking forward to the other presentations. Thank you.
Thank you, Dr. KORGE. A marvelous speech. You are focusing on the complications avoidance of spinal microsurgery. We all know that spinal microsurgery still play a very important role in the field of minimally invasive spine surgery, although there are more and more endoscopic surgery. Still, spinal microsurgery is important in this field. So, any question toward the Dr. KORGE's speech?
Perhaps.
Yes, please.
Yes, I'm Dr. Tanaka. Thank you for a wonderful lecture. So my question is about dural tear. So my favorite one is staple. It's anasto clip. It's becoming very popular in Japan. How about your country or your opinion about the clip, anasto clip?
Well, thank you for this very wonderful comment. And I apologize for not having the staples in the presentation, but that's completely a very, very good argument. However, the only thing is they are expensive, and therefore we don't have it. It's very elegant. You can even use it on the C-spine. I will put it in the next presentation whenever I have a talk again for dual tear. You are completely right. A very good comment. It's a little bit expensive, so we don't use it.
Okay.
Thank you.
Thank you.
And can I have a question, Dr. KORGE?
Always. Yeah.
It's also about the dual tear stitch. We all know that under the normally spinal microsurgery, especially to the lumbar spine, we did the surgery under the tubular retractor, normally the fixed tube. So the diameter of the tube might be 18 or 21 millimeter. So under that condition, would you please talk us more details about the dual closing by stitch? Do you have any special tool or just some special skill to that?
Well, no, I think to be honest, it is independent whether you use a tube or whether you use a retractor system. The tube with 20 millimeters gives you some space for suturing. I mean, for suturing the dual tear. If it's a small one, if you can use some kind of this padding or like flows like Tachosil or so. I think it's even with a 10 or 15 millimeter approach, you can put it on. Of course, if you have a large dual tear, if it's not manageable by using a tubular surgery, I think you just have to take out the tube and go for a retractor system. 2 or 3 stitches, from my point of view, the most important thing is that you use micro instruments and that you have to switch off from standard instruments to the micro instruments, because even a micro scissor or even a micro needle holder is much smaller than a standard needle holder. With a big needle holder and with a non-bayonet shaped needle holder, it is not possible in a tubular situation or even in a retractor situation to close the dura. So you need a micro set for this, for handling this problem.
Okay, thank you. So thank you very much. We are a little behind the schedule. So let's turn to the second speaker, MASATO TANAKA. Let me also have a brief introduction of Dr. MASATO TANAKA. MASATO TANAKA is the president of the Spine Center, Okayama Rosai Hospital. He is also vice president of Okayama Rosai Hospital. We all know that. I know Masa very much since a long time. He is now Spine Asia Pacific education officer. He is also vice president of Smiss AP 2022, president International MIST 2022, president Japanese Society of Adult Spinal Deformity in 2017. He is also clinical professor at Okayama University Hospital. He was the winner of the Spine AP Regional Educator Year Award. So let's have Dr. Professor Tanaka. His speech, the title might be the complications, consideration, and avoidance of OLIF and LIF. Dr. Tanaka, please. Masa.
Oh, yeah. Can you hear me?
Mm-hmm. Yes.
Thank you for your introduction. My name is Masato Tanaka from Okayama, Japan. Yeah, about our knowledge about the complication of lateral approach. Let me begin with this case. This is 79 years old female, adult spinal deformity. We have a lot of this kind of patient.
Masa, please share your slides.
It's not really?
Yeah, it's not on the air.
Sorry. How about this?
Yes. Yes.
Sorry. But it's sorry. What's wrong? Something wrong. Sorry. How about this? Okay.
Yeah, I can see the screen.
Okay, sorry about that.
Yes, good.
Okay. my lecture is about the complication of lateral approach. So let me begin with this case, 79 years old female, adult spinal deformity. We have this kind of patient because now in Japan, we are suffering from graying of the society. For this patient, we can perform this kind of correction with MIS technique. This is a famous paper from Japan, so 2017. So at that time, so direct lateral approach was common compared with oblique lateral approach. However, the total complication rate is much higher in direct approach, direct psoas approach, 19% versus 15%. So it's mainly because for X-ray direct approach, so you cannot monitor sensory nerve, and also you have to split psoas muscle. That's why the complication rate was higher. This is another paper from Japan. So from 2015, between 2015 and 2020, so transpsoas approach and prepsoas approach are almost equal. It's mainly because for oblique approach, it is no need for neuromonitoring. And also, if you use OLIF technique, you can access L4-5 very easily, and also L5-S1 as well. So if you look at the complication, number one is sensory deficit and motor deficit, weakness of psoas, and lumbar plexus injury. SSI, for every kind of procedure, the surgical site infection is very common. And for LRIF, the vertebral fracture is one of the most common complications. Totally about 3% complication rate. As you know, for deformity, it's very difficult to put the cage. That's why among all procedures, the deformity surgery is the most common. So another complication, major vascular injury, ALL rupture, bowel injury, and major vessel injury are sometimes fatal complication, as you know. This is the contents of my talk. First, I would like to talk about preoperative planning and position, patient position. So for patient positioning, you shouldn't break the table too much, because if you break the table too much, you elongate the lumbar plexus. That's why it's a high risk of lumbar plexus palsy. And also, so if you would like to put the cage from L5-S1 into L5-S1, if the angle is like this, so the pubic bone prohibit your surgical field. That's why this is a contraindication for OLIF 5-1. Another complication is high rising psoas. So 4-5 is a high incidence of high rising psoas. So if you look at this red arrow, the red psoas is high rising. So if you approach the direct lateral approach, it's a high risk of nerve plexus injury. Another problem is if you look at this red arrow, so there is a vessel here on the psoas muscle. This is ovarian vessel. So you should pay attention to the preoperative image, especially for MRI and CAT scan. Another problem is IVC location. So there is a paper from Japan. So if the IVC is located zone 2, it's a high risk of vascular injury. So for LRIF, you have to penetrate the other side of the annulus. So if you penetrate a lot of, so this vessel will be collapsed, injured. Let's move on the next topic. So ORIF 5-1. So 2 finger widths from iliac crest is very important to not to injure the hypogastric nerve and ilioinguinal nerve. So if you retract the psoas muscle more than 25 minutes, it's a high risk of lumbar plexus palsy because of the nerve ischemia and direct damage. As you know, there is a safety zone for lateral approach, especially for transpsoas approach. So especially L4-5, if you look at this figures, the nerve root plexus is almost 1/3 of the posterior part. So you shouldn't injure this nerve. For ORIF, usually neuromonitoring is not necessary, but in our hospital, we always perform neuromonitoring, even for ORIF technique. Another problem is anterior longitudinal ligament tear. This is relatively common. In our hospital, we experience about 3% of ligament injury. Let me show our case. This is adult spinal deformity surgery. We put the 4 cage from lateral. If you look at this image, L4-5 cage are a little bit weird. This is a post-operative X-ray and CAT scan. If you look at this cage is protrude anteriorly. If you look at axial scan, it's almost okay, but we shouldn't have such a courage. If you injured the ALL, maybe you shouldn't put the cage. This is another case, other spinal deformity. L1, L2, I injured anterior ALL. If you look at the postoperative CAT scan, so this is almost like anterior column release. Then we experience rod breakage. So if you cut ALL, you should put additional rod like this. Or nowadays, we can use cage and plate, or another solution is a special cage with screw to prevent backout. So another problem is vertebral fracture. This is L4 spondylolisthesis case. This is our case. During LRIF surgery, we injured end plate. So salvage, one option is put a longer cage like this. Another problem is sometimes you put the cage into vertebra. If you look at this, one cage is into the vertebra. In the station, I put dual cage like this for salvage. How to prevent nerve injury? This is a big issue for us. This is also my case. 24 years old, spondylolisthesis. I perform L-lift 4-5. After the surgery, the patient complained leg pain. So this long cage, it exiting nerve root. So 4-5, because of the big push-offs, high-rising push-offs, the cage is always put like not straight, it's like oblique position. So if you put a long cage, it's a high risk of exiting nerve injury. We should remember that. Another problem is retrograde ejaculation. In Japan, for ORIF 5.1 or ARIF 5.1 is very popular. If you perform ORIF or ARIF for retrograde ejaculation, incidence is higher one is more than 20%. So in my opinion, so for younger male, this ORIF or ARIF should be a last option. However, so this retrograde ejaculation, transit one is about two-thirds. And to prevent this is we shouldn't use bipolar or monopolar. So let me show you our technique. So we never use Shyam. We call this technique is Shyam-free ORIF. Always we use navigation. This is navigated shape. Navigated core. Most important one is actual image. Navigated curate. Trial is also navigated. You can measure the length and then put the cage like this. Final one is how to prevent vascular injury. This sometimes you use this kind of pin to fix the retractor. So this pin sometimes injure segmental vessel. You should pay attention to segmental vessel. This is a small vessel, but if you injure this vessel, a lot of bleeding, because retroperitoneum is there's nothing to prevent the bleeding. So, but usually the bipolar is available. Another one is ORIF 5.1. Anatomical consideration is very important. We call this vascular wind. More than 20 millimeters are necessary for this technique because the cage is very big. In our report, so approximately 20% of total cases are contraindication for ORIF 5.1. Let me show you the ORIF 5.1 technique. Now I'm retracting the bifurcation of greater vessels. These retractors have an excellent elimination. That's why you can see the L5 S1 disc very clearly. Remove the disc with exactly the same technique of ARIF, but this is lateral position. Now I am confirming the location with navigated probe. This is the image. Remove the disc completely like this. And then put the cage. The new cage, nowadays you can navigate it, L5S1 cage as well. This is a screw to protect back out. If you put ORIF 5.1, we compare with ORIF TD 5.1, you can create good lordosis at L5S1 level. Take-home message of my talk. So complication of direct lateral approach is higher than that of oblique approach. Top 3 complications are nerve root injury, psoas weakness, and vertebral body fractures. Major complication of LRIF are bowel injury and vascular injury, which are sometimes fatal complications. Preparative planning is very important to prevent complication. Thank you for your attention.
Thank you very much, Professor Tanaka, for the perfect lecture. We all know that LIF and OLIF techniques is getting more and more popular almost in every corner of the world. And we treat the spinal patient with OLIF and LIF more and more. So it's really a fantastic surgery with intramuscular and intermuscular approach. So it's a real minimally invasive spine surgery. But for some cases, I think the complications are minor, but once upon it happens, sometimes it's fatal. It might be fatal complications. So thank you very much, Dr. Tanaka, to give you such a perfect lecture. Any question?
Question.
Do you have any question toward the Dr. Tanaka's lecture? Masa, I have a question, the brief question to you. I mentioned that for the adult spinal deformity, to your most of your cases, you just download the fixation to the pelvic. It gives the negative influence to the daily life, especially to the East Asian women, East Asian people. So what do you think about this?
Preoperatively patient very severe symptom. So I already explained to the patient. So maybe 90% you can wear your socks by yourself. But maybe it's very difficult to cut your toenail because you have to bend, and you have to give up guarding. It can be helped. But usually this kind of patient, very severe symptom. So, and as you know, for toilet, in Japan, we have a washlet. Very effective.
That's a kind of a solution. Okay, thank you. Any other questions? So thank you again, Professor Tanaka. Let's turn to the third speaker, Professor ARVIND KULKARNI from India. Let me have a brief introduction before the lecture. Dr. ARVIND KULKARNI is one of the pioneers of minimally invasive spine surgery and artificial disc replacement in India. His special interests are minimally invasive spine surgery, deformity correction, artificial disc replacement. He is the chief of Mumbai Spine Scoliosis and the Disc Replacement Center, Mumbai. He is a consultant spine surgeon at the major hospitals, Bridge Candy, Mumbai, HN Resilience, and the Saifi Hospital in Mumbai. Meanwhile, he has many academic achievements. There's a long text to read. I just skip a little bit. Forgive me, Dr. KULKARNI. Let's welcome Dr. KULKARNI to give his speech on to the tubular spinal surgery. Complications, consideration, and avoidance. Dr. KULKARNI.
I thank you for this humble introduction of mine. I would like OrthoTV to help me, to load my slides here. Maharshi?
Yes, sir. Yes, sir.
So I'm going on the window, but I don't see anything happening here.
Let me check. You want to share screen, sir?
Yeah.
So just click on share screen.
Yeah, I've done that.
Yeah. Yes, sir. And click on screen.
Yeah.
Now, sir, you can go on file and check the video or
No,
or PDF.
one sec. Can you see my screen?
Yeah. Yes, sir. Yeah,
Sure.
now it's perfect, sir. Yeah.
You can see the title screen?
Yes, sir.
Okay. Dr. Liang, can you see my screen?
Yes, I can see.
Okay. Again, so thank you for inviting me for this webinar. Complications are a part and parcel of surgeon's life. So much so that, I am the deputy editor of JMIST, and we had a special issue last year on complications in minimally invasive spine surgery. It was a big special edition issue, almost covering about 200 pages. So complications are a big burden on us. They are rare, but they are frequent with inexperienced and overconfident surgeons. So I am a tubular spine surgeon, and I find that tube is magical. So look at this particular patient with severe L4-5 stenosis. The dural sac is almost invisible. It's totally a dark tunnel there. And using a small tubular retractor, which is as small as 16 millimeter diameter, you can achieve an excellent decompression while preserving the soft tissues as well as the bony structures. So that is the beauty of minimal access. At the same time, it can come with complications. So it is a similar surgery, severe L4-5 stenosis. This lady was about 75 years old. She underwent this particular surgery. She had an excellent post-operative outcome. She walked home the next day. But after a 4 to 5 days after surgery, she started, sensing droplets of fluid leak in her back. And she ignored this particular situation, and she did not come back to us till she developed, florid meningitis. So the meningitis was so severe that even after admission with debridement, with antibiotics for going on for almost a month, we lost her. She died, and this is one reason why this is one of the factors which helped, which prompted us, which triggered us to form this particular spine surgery checklist, which not only has pre-operative components, but also intraoperative, as well as, most importantly, in this particular case, a post-operative components where the patient is advised to come back to us in case there is something like this happening, some unpleasant situation happening after surgery, just like this, fluid leak which the patient was not aware of. So the spine surgery checklist goes a long way in preventing complications. So when it comes to MIS, I have categorized my today's talk under these particular headings. So the scar of minimal access spine surgery is one of the attractions why patients come to us. So this is our trump card. This is our hallmark. This is something which we describe to the patient, that, your surgery will be done with not a long, treacherous incision, but a very small, incision which will probably disappear over a period of time. So this is one of the attractions. And you can't get such dirty wounds, patients come back with such dirty looking scars later on in your clinic. So the reason for such situations happening is because you're trying to put, trying to put a big tube through a small, narrow incision. So I would suggest the way to avoid this is to take a slightly longer incision. So if you're using a 12 millimeter tube, use a 14 mm incision. If you're using a 14 millimeter diameter tube, use a 16 mm incision. If you're using a 18 mm tube, use an incision which is as long as 20 millimeters. That is the only way of dividing, minimizing such a complication. And we should not bother about these incisions, because a clean looking incision later on, all scars contract. So even if it is a 2 centimeter incision, over a period of time, it shrinks and it is hardly visible. So we had this interesting study in our clinic where we recorded the priority list of these patients who came to the clinic. So we gave this list of 12 questions to the patients and asked them to mark the order of priority they would choose, with regards to their outcomes. And the size of the scar was 8th on the list compared to the rest of the symptoms. So scar is important, but is not very, very important. Now coming to localization and orientation. So this is the key of minimal access surgery, because we don't expose the spine. So it is very important that we have our landmarks right. We land at the right side when we need to operate. So why does this happen? This happens with loss, when you don't have skills, when you're not trained well, these kind of situations occur, and it has a learning curve to learn this kind of these skills. So the most common landmark that you feel is with your first dilator is the junction of your spinous process and the lamina. So that is what you feel when you're doing a tubular discectomy, when you're doing a tubular decompression. So these are two common surgeries that we perform within the tubular retractor. So it is very important for the early beginners to keep practicing as to how to feel the base of the spinous process, how to feel the lamina, how to feel the inferior border of the lamina, the slope of the lamina with the first dilator. So something that is similar to this kind of feel is the junction of the transverse process and the superior facet. So this is a similar feel, and it is possible that sometimes initially in your initial days you might mistake the spinous process for your superior facet and the lamina for your transverse process. And the only way of bailing it out is to check it on your Shyam once more in AP as well as in lateral, and beneath the skin go a few millimeters medial and get to the right spot, and that comes with experience. Again, a few millimeters here and there makes a big difference when it comes to surgery. For example, this patient lateral recess on this particular ipsilateral side needs to be decompressed, and if you are a few millimeter away with your first dilator or your guide wire, you will end up in the facet, and if you end up on the facet, you can create instability if you're not aware of the anatomy. So it's very important that you study the anatomy of the patient very well. You can have patients who are small in size, you can have patients big in size, you can have morphometry which is small in size, you can have morphometry which is big in size. So it is very important that you customize your entry point, your landmarks based on the patient's anatomy. So as I said, you have to customize your parameters according to the patient, according to the level. So the spinous, the vertebra are smaller at the upper lumbar levels. The lamina are wider at L4-5, L5-S1. So this has to be ingrained in your system when this should come naturally to you when you're operating on patients. And again, your localization varies according to the surgery that is planned. So if you're doing a discectomy, it's somewhere here, your red spot that you need to land on. Again, when you're doing a decompression, it will be slightly medial because you need to go on the opposite side. But when you're doing a TLIF, you will be on the facet joint. So it is very important that the spot at which you land is customized based on the surgery. Again, it is very important to have a good quality Shyam machine. So see, look at this AP image. It's so bad. It's better to do an open surgery in such a situation rather than go ahead with a minimal access surgery. See, this patient is rotated to one side. Okay, and if you follow the natural parameters, see where will you land up? 1 centimeter away from the midline is you will be absolutely off center. You will not only harm the facet, you will be absolutely off the intervertebral disc parameters. So it's very important to have your spine square. It's very important to have your Shyam absolutely square so that there is absolute symmetry. Because facet violation leads to instability. This is well known. There are some papers which claim that endoscopic facetectomy doesn't have any bearing on instability. I would take it with a pinch of salt. Again, the Shyam should be parallel, should be perpendicular to the lateral image that you take should be perpendicular to the spine, not perpendicular to the table. So if you have a degenerative scoliosis patient and you are planning to do a TLIF or a decompression procedure, and if you take a bang lateral, which is lateral to the perpendicular to the table, you will end up at an unknown territory. So it's very important that your Shyam in lateral image is perpendicular to that particular segment in this particular direction and not lateral, perpendicular to the table. Again, you have situations, especially in upper lumbar levels, where the the facets are absolutely close. They're extremely close, and if you have to do an ipsilateral decompression, you'll end up eating up the facet. So in such a situation, the concept given by the tubes is to go from the contralateral side. So going from the contralateral side will minimize your injury to the contralateral facet and will not injure your ipsilateral facets. So this is way of maintaining stability as well as at the same time achieving your goals of decompression. So these techniques, these options as to where to enter the canal from, we have discussed in this particular paper, which is published in Spine. So this basically deals with the side of entry, in different situations. Again, we also described how it is the angles at which you operate are different in narrow canals and wide canals, comparing L4-5 versus L5-S1 in this particular paper. Now look at this particular situation where we did a 2-level TLIF, and in the lateral, the cage is right in the disc space, but when you do an AP, it's gone out of the canal, out of the parameters of spine. It is jumped into the retroperitoneal area. So this can happen if your orientation is wrong. So you see, we had to put another cage here, and this particular cage we had to remove by doing taking a small incision in the inguinal region. So this happened because the patient, for decompression, the patient was rotated on the opposite side and was not derotated when you're putting the cage in. So when you take a lateral, when the patient is square, so you're in the right spot. But if you're taking a lateral when the patient is rotated, so you will not realize that your cage is gone to the opposite side, but still it will be seen as if the patient, the cage is in the disc space. So it's very important that your orientation with regards to the rotation of the spine is absolutely clear when you're operating at different steps. Next would be inadequate decompression. So this happens because of poor knowledge, poor skills, loss, minimal experience. So this is not because of limited exposure, because the tube has a lot of properties. The tube is very versatile. So this basically happens if you are not skilled enough, if you are not trained well, and if your orientation is poor, and if you feel that the tube only provides you a tunnel vision. So you see here, this is a pre-op images. There is stenosis. In one of the post-operative image, the canal is decompressed, but in the successive axial sections, the canal continues to be tight. So this is because you don't know the properties of the tube. Whoever is doing this particular case, the tube can be, the tube is very versatile. It can be angulated medially, laterally, and it can be angulated quite well superiorly as well as inferiorly. It can be swung up and down to very great extent. So you should use the properties of the tube. So right from its exit from the dural sac till it goes beyond the foramen, the tube should be tilted, and its entire course, the entire course of the traversing route should be decompressed. Now, the difference in good and bad surgery is how well you treat the soft tissues. That has a bearing on preventing infection. So we had published this paper after we did about close to 2,000 cases of minimal access using tubular retractors. There was hardly any infection in tubular decompression and tubular discectomy cases, but we had 3 infections in patients who had undergone a TILIF. And such a occurrence in necrosis or wound infection occurs, if your tube is very superficial. So if your tube is very superficial, you tend to burn a lot of muscle, you tend to burn a lot of soft tissue. That creates a lot of wound necrosis. So it's very important that you keep dilating the tissues at every level that you reach. So if you reach superficially, take an incision at that particular level through the soft tissues, insert your dilators once more, go deeper. Again, if you're still superficial, take an incision again, put your dilators once more, see to it that you keep repeating these steps till you reach bone. This is the only way of minimizing wound necrosis. So what happens if there is a hypertrophic facet and you have to do a TILIF? So you don't have to burn all the soft tissue that is there in this valley between the spinous process and the facet joint. What you need to do is you land on the facet, you drill the facet till it is flat with the lamina, then you put a deeper tubular retractor, then work on it. This is one way of preventing soft tissue injury and then infection. Again, CSF leaks are part and parcel of a spine surgeon's journey. They could be minor, when there is a fountain like this, or you could have a situation where there is a big tear and the rootlets herniate. The incidence of this happening is about 6.3% on an average. So the minor tears, like the ones like a pinhole, they can be left alone. You can put some fat, then place a gel foam and do a watertight closure. So there is an elastic recoil of tissues, because once you remove the tube, there is hardly any dead space. The wound, the muscles, soft tissues approximate, and you take a watertight skin closure. Usually it doesn't trouble you. If there are major tears, there is a tendency to panic. So what one should do is not panic. Keep a piece of patty on top of the rootlets. Complete your decompression, especially the caudal side. Complete your decompression thoroughly. Remove the hourglass constriction. Once you do that, the dura becomes lax, and the rootlets can be easily placed into the dural sac. And then you spray, TCL, that is fibrin glue. Most of the times, this has helped me in my practice. If it still cannot be managed, the only way is to open and close it as shown here. So how do you avoid dural injuries? How do you avoid nerve root injuries? Thin out the cortex of the lamina with the burr. Don't use large size punches. Don't plunge them into the canal. Avoid osteotomes. Complete all bony work before you start working on the flavum. And be in the interface in the right plane between the flavum and dural sac. Tilt the tube in all directions liberally. So this is one of the reasons when you're trying to kink the kerison within a limited view within the tube, you tend to cause these dural injuries. So let the kerison be in the plane in the same direction as your tube. And avoid guide wire when you're localizing levels, because if you use a guide wire, there is a chance of having a dural tear before you even started your surgery. So there are many other issues with the guide wire. They can fracture, they can cause ileus, they can cause infection, they can perforate the bowel if they go into the retroperitoneum, they can cause RSD, they can cause vascular injuries. Once the guide wire is in the wrong place, it increases the operative time and the radiation exposure. So finish all your bony work as shown here before you work on the soft tissues to avoid nerve injuries. One more reason why you can have a nerve injury is failure to derotate. So you do a ipsilateral decompression, you do a contralateral decompression when you're doing a TLIF procedure, and if you don't rotate the patient and try to push in your cage in the angle, then you can retract the dural sac and cause neural injuries. Again, if your docking is too medial, you can injure the dural structures. Wrong level surgeries are uncommon in tubular surgeries because still the tube is docked on the level which you're going to operate. You have your Shyam shoots, so it's very unusual to do a wrong level surgery. Bleeding, Dr. KORGE has already described how to manage bleeding. The usual tricks with regards to positioning, keep the abdomen free. I've seen more bleeding from the cavernous trabecular bone in osteoporotics rather than the epidural bleeding. Again, as Dr. KORGE suggested, burr itself acts like a hemostatic. Bone wax, use it liberally. Bleeding may not be a big issue because as soon as you remove the tubes, there is an elastic recoil, there is a tamponade effect which prevents collection to the extent that we don't even stop aspirin and clopidogrel in patients who are high risk of getting stroke or MI, myocardial infarction. We have been able to manage them without stopping their aspirin and clopidogrel and continuing with tubular surgeries. So to conclude, complications are part and parcel of a spine surgeon's practice. In the early beginning, it is because of lack of experience, and later it is because of arrogance and overconfidence. Mostly these complications are because of a lack of three-dimensional orientation, unlike open surgical technique. Poor skills and technique add to it. The way you should avoid a complication is to treat each case as an important case and as your first case. Thank you.
Thank you, Dr. KULKARNI. Thank you very much for your perfect lecture. You were focusing on the complications avoidance of the tubular surgery, tubular spine surgery. You are focusing on you talked a lot about the how to prevent the nerve root injury, wrong level surgery, and how to prevent the guide pin misplacement, things like this. I enjoy very much your last statement that you should consider treat each case as your first case. That's a very, very good expression. Thank you very much. I would ask any question to the lecture of Dr. KULKARNI. Yeah, can I have a question to you, Dr. KULKARNI? I noticed that you enjoy very much tubular spine surgery. First question is, do you prefer the fixed tube or expandable tubular retractor? The first question. And second question, I noticed that you did surgery under 15 diameter tube, so it's very tiny. So do you have any special equipment, tools to deal with the patient during the surgery?
Yeah, so the first question, I have stopped using the expandable retractors almost about 15 years back because they are very weak. the walls of the expandable retractors are very weak.
Yes.
They are not
Yes.
as strong as as the single tubes. So maneuvering the tube, tilting it in various directions, it's not possible. And there's a lot of soft tissue creep between the blades of the expandable retractor. And I don't enjoy it. It is as good as doing an open surgery for me, using the expandable ones. And the smaller tubes, the only problem I have with the smaller diameter tubes is the bipolar. As soon as it goes in, the bipolar closes.
Yes.
So that is the biggest challenge. Otherwise, I have smaller, I use number 2, number 1 Kerrison in such situations. With practice and time, it's possible to operate using the same instruments through these narrow tubes. The only issue is the bipolar.
Okay. Under the microscope, always, right?
Yeah, correct.
Okay. Any other questions? Dr. KORGE, do you have a question toward the Dr. KULKARNI's lecture? Any comments?
No, I followed it with a lot of fascination and very interesting things. But at the end, you summarized everything perfectly about the easy steps, which sometimes as a prophy, for us, it's easy, but for the beginners and for those with less frequency in your daily practical surgical training, they usually don't see the easy problems, which we know how we can shift around and circulate around. So it's a very important presentation from you. Yeah, thank you. No further questions.
Okay, thank you, Dr. KORGE. So thank you again, Dr. KULKARNI. Let's turn to the last, but not the least speaker, Professor Jiang from Beijing, China. Always before the lecture, let me have a brief introduction of Dr. Jiang. Dr. Jiang is a very active minimally invasive spine surgeon in China. He is now director of Department of Minimally Invasive Spine Surgery, Beijing Haidian Hospital, Peking, affiliated to the Peking University. He is an AO endoscopic spine surgery faculty since 2019, and he's also a faculty member of our Smiss AP faculty since 2019. So his topic is very interesting because, we all know that spinal endoscopic surgery is getting more and more popular, especially in China, in Korea, in Germany. More and more spine surgeons, especially young surgeons, are dedicated to the endoscopic spine fields. The indication is getting wider and wide. So today, Professor Jiang will talk with us how to avoid the complications and how to avoid the avoidance of the endoscopic spine surgery, especially in the cervical spine and the thoracic spine. Let's welcome Professor Jiang.
Thank you, Professor Liang.
And actually, Professor Jiang is very busy. He is now in Cairo, Egypt.
Yes, thanks you for all. And Professor Liang, actually, I'm still in jet lag. And I heard 3 professors talk about the microscopy, tuberoscopy, and olive, and focus on the lumbar surgery. So I would like to talk about the complications and avoidance for the endoscopy procedure in cervical and thoracic spine. The procedure in the cervical and thoracic spine by the endoscopy is not popular in like the lumbar surgery. because it has some it's very difficulty and has some unique complications. Maybe it's disaster and a nightmare for the surgeon. Last year, the Korea also reviewed a very good article named "The Complication and the Management of the Endoscopic Spine Surgery." Today, I will talk about with this article and combine my cases and the experience, maybe my nightmare here. In word, it's a 5% with both anterior and posterior approach complications in cervical surgery and endoscopic surgery. It's very familiar with the open procedure, but the some complications is not like the open surgery. Open surgery, some complications made in the some special procedures. And according to this picture, this articles, we can find the laryngeal nerve injury and the swallowing dysfunction is the unique complication in this anterior endoscopic procedure. It's not like our open procedure. We can distinguish the structures I mentioned above. We can avoid all these disaster complication. But in the PCED, I mean the endoscopic percutaneously endoscopic procedure, we can't find this important structure with my eyes. We only to use some the two-finger technique to avoid this structure injury. But it's not easy. And anterior endoscopic cervical discectomy seem to be effective with decompression, but there's no help for reconstruction of sagittal curve, and it can't reconstructive design, just like in my cases. In these cases, you can find we can decompress. We can't say it's enough, but maybe the symptoms relieves, but the kyphosis is still here. So the anterior procedure, the percutaneous endoscopic cervical procedure has its own control indications, such as migrated disc herniation, calcificate disc, collapsed disc space less than 5 millimeters, and the cervical instability, infection, and have the past history of anterior cervical surgery. And this procedure has its critical skill. It's a two-finger technique. We all use our two fingers, index and the middle finger, to push away the diasterial structures and arterial structures for a safe window. But sometimes for some fat patients, this safe window is not enough. So I prefer to change to use the endoscopic assistant cervical surgery. This is I use a small endoscope and to help us to making a clear region, and we can make a precision stop bleeding and decompression. I think in the water situation it's more easy, but I use the traditional open way to expose the disc first, and then I transfer to the endoscopy procedure. I think it's more easy and more it's help us. And however, the posterior cervical procedure is a good choice. Since 2007, the doctor routine review this procedure. I love this procedure. It can not only decompress the deal with the herniation, but also the stenosis. In the posterior cervical surgery procedure, they have the same the complications, just like the transit hypoxia and dural tears and motor deficit, just like this, and hematomas. And neck pain and nerve injuries is very common in this procedure. This is my cases. My cases is a female, 46 years old, and under some weakness in left upper limbs for 1 month. We can see a paramedial herniation in C5 and 6 segment. We do the posterior approach for the discectomy. This is the MRI in 2 days post-operatively. We can see the decompression is good, but 5 days past, the muscle strength of the left upper limb was significantly decreased without numbness and pain, and the relax is disappeared. We have to check the MRI again. We find the spine cord swollen and maybe injured. And after 1 month, the edema is limited. And after almost 3 months, the spinal cord recovered. So in the posterior decompression by endoscopy has his control indications, such as the calcified disc, cerebral stenosis, colloidal syndrome, painless weakness, cerebrofibrillary adhesion, and just like the pyogenic spondylodiscitis, several spinal infection. He has a critical skills. Stop bleeding and keep a clear view is very, very important, because you face to the spine cord is not a nerve root, it's more easy to injury. On the reasonable area of decompression in case of the instability is also important, because if you do extra decompression, it's not only to lead to instability. Sometimes maybe you can lead to injury the artery. Yeah, the artery, the vertebral artery. In my cases, I have once I find this vertebral artery, but I'm a lucky dog, so I didn't injure it. And you need more experience with the URBD technique in the lumbar. I like to choose the big size endoscopy with the throated design. It's maybe more safe because it's the physician is very stable, very stable. Yeah, that's very good. It's short, more short than the Euro, than the Euro. So we can use some special equipment and tools to do the compression. Yeah, this is my patient is the pre-operative here and post-operative, just like the lumbar. It's very similar. It's very similar, but in the cervical procedure, it's more I can't say easy, but more more short the work time for this, because the structure around the posterior cervical is not big. About the thoracic disc herniation, it's rare in the clinic, and only less than 2% need for surgery. And endoscopic transfemoral approach about the thoracic surgery, and the costal neuralgia is unique complication. I met one case in my work. This is the case. It's a male, 62 years old, walking weakness in both legs, accompanied by the urinary problem in 1 month. He got he suffered a fusion surgery 6 years ago. We can the ASD here. We can find the ASD here, and it's only a herniation in 2 segments, but it's irritated the spine cord. Here, we do the transfemoral procedure for the decompression. Just like here. Yeah, 2 segments. In the thoracic decompression, it's not like the lumbar transfemoral decompression. It's not in a big area for us doing the foraminoplasty, and the thoracic spine has the narrow disc space, so we can't put the canal into the spine canal too much. So we must do more the foraminoplasty. We can do more and more the bone work for the decompression. And the complications of full endoscopic transfemoral thoracic surgery is just like sometimes the headache, recurrency, and dural tears, nerve injury, just like this. There are 3 main complications. It's neurological injury. Maybe the direct injury, maybe the irrigation injury, maybe the high irrigation pressure injury, and the second is the vascular injury, and vascular injury is not common. Otherwise, and the dural tears and epidural hematoma, transit dysphasia, and the complete compression is also we can make. This is a T3, the OLF. And compared to the transfemoral decompression, I like to do the posterior decompression for the thoracic spine surgery. Just like this, it's ossified the OLF here. This is the posterior MRI and the post-operative CT scan. It's a 3D construction. When the OLF combined with the dural ossification, is very dangerous in this procedure. Just like this, and this is cases came from my college, my workmate. This is a severe OLF combined the dural ossification. We do the endoscopic posterior decompression procedure, but the dural tears, and this is a local anesthesia, and the patient the patient this general anesthesia, and after when the operation finished, the patient showed the seizure symptom. We call this is the hypertension symptom. And the decompensation insufficient is common, but it's very can lead to a disaster results. This patient is male, and T10 and T11 OLF. And we do the decompression with the endoscope, but the first time we don't the contralateral decompression is not good. So when the finish the operation, the patient no change of the symptom. So we do the we transfer to the not transfer. We selected the open surgery traditional surgery to do this again. Maybe after seven days. This is the picture intraoperative. We can find the decompression is not good. We do it. We take off all of the lamina and the puzzle of the facet joint. This is the CT scan and the preoperative and the first postoperative and revised. And extra decompression lead to the contralateral facet joint injury. Sometimes we can find these complications, but in thoracic segment, because we didn't find the instability in the short follow-up. In case of to injury the spine cord, we suggested that we could build up enough space for decompression. Which means when we want to take off remove the OLF, we should create the enough space, including the base of the sphenosis and the facet. Just like this, when you want to remove this OLF, but if you want to do this, the instrument always to irritate the spine cord. So we need to use the reamer to create more space for the decompression. When created the space is enough, we can use the Carson rounder to deal with the OLF. It's around the spine cord, not to direct push the spine cord. It's more safety. Just like this. So in the thoracic surgery, the control indication is to say the severe kyphosis, severe ossification of the ligamentum flava with the dural calcification and several ossification of the PLL. The critical scale is to build up reserve enough space, keep a clear view, and design the decompression range bounder, and reserve the drainage if necessary. So in thoracic surgery and thoracic sometimes it's a disaster and a nightmare for the surgeon and patients. So good luck for everyone. Love the change and the scopic decompression in the cervical and the thoracic procedures. Thank you. That's all.
Okay, thank you, Professor Jiang. Thank you for your excellent speech, focusing on the endoscopic surgery onto the cervical spine, the thoracic spine. You are just concentrated to the complications avoidance during the surgery and after the surgery. So it seems to me there's just a no forbidden zone to the endoscopic surgery. At first, we did the endoscopic lumbar spine surgery and then cervical spine, endoscopic cervical spine surgery. And then nowadays, we hear and saw a lot of cases of endoscopic thoracic spine surgery. So congratulations. Any questions toward Professor Jiang's speech? Any comments?
Yeah, I have a question. So he showed one case of Dr. Jiang. You showed me a case of cervical disc herniation who deteriorated after the operation. The MRI got better with time. How about the clinical scenario? Did he improve clinically?
You mean the cervical discectomy?
Uh-huh. You showed the
No.
progression of, you showed how the edema regressed on the MRI, but what happened to his neurology?
Oh, my patient. It's my patient. The spinal cord injury. Yeah.
No,
Maybe 3 months. After 3 months, this woman recovered, but still has some the sensory deficit.
Thank you.
I'm lucky.
Masa, do you have questions? Masa?
So as you know, nowadays, UB is very popular. For posterior approach, maybe UB is the best, but for cervical anterior, so can you use UBE, two-porter technique for
Sorry, I
cervical?
lost you.
Can you? But
Yes, sure.
biporter technique for anterior cervical, can you?
Yes. I used the UB technique for the anterior approach for the cervical surgery and the posterior thoracic surgery. But I didn't like use this technique in the posterior cervical surgery because I think the cervical structure is not big. It's very small. The full endoscope is enough and very effective for this procedure. It's my opinion. It's my opinion. Only my opinion. In China, many surgeons like to use the UB technique deal with the cervical disease. We use this technique, do the keyhole technique and the flatwood technique, all of this technique. But I prefer to choose the full endoscopic technique for posterior approach in cervical surgery. But however, in thoracic posterior approach, I prefer to. I very like to use the UBE technique because the high speed electric burr and can create it and prepare more space for do the OLF decompression. And it's easy. And we can use many suitable equipment to do this. So that's a hook, a little hook, and a QWERTY. But in the full endoscopic technique, we don't have this a good equipment used in this procedure. It's my opinion.
Okay, thank you.
Thank you. Any other questions? Are we? Again? Dr. KORGE? Okay, perfect. The time flies fast. So let's have a wrap up. So today, thank you very much for all the speakers and for all the audience online to join this Smiss AP webinar 2024. Today's topic, today's theme is complications of MI and how to avoid them. We have 4 speakers, ANDREAS KORGE from Germany, MASATO TANAKA from Japan, ARVIND KULKARNI from India, and JIANG from China. They just gave us an excellent speech focusing on the spinal microsurgery, tubular spine surgery, and lateral approach surgery, and endoscopic surgery. Those speeches are so impressive. So I hope the audience and including us learned very much from your contribution, and I appreciate very much your time and your contribution to the success of this seminar. So at the end, I just think about there's a Chinese proverb that says 行稳致远, steady working makes far-reaching. So when we starting a new technique of including spine surgery or in the other field of surgeries, we have to learn the steps, the technique in detail. So we have to realize the complications associated with each specific techniques, including all the parts of minimally invasive spine surgery. So I hope with this prudence and so-called patience and prudence, we will reach much far from them. So thank you very much. Thank you for joining us, and I appreciate it very much. Thank you. So now we close the meeting. Thank you again, everybody.
Thank you. Perfect.
Yeah, bye-bye.
Thank you.
See you a lot.
Bye-bye.
Learn a lot.
Bye-bye. See you next time.
See you.
See you next time.
Yeah.
See you.